topic of the teaching today is urology, robots, and laparoscopy, which is a surprisingly broad topic, really. But we shall see how we get on. So I mainly aim this at sort of pre-primary / coming up to primary type level. So Tom, Cav, you'll probably know most of the stuff / all of the stuff that I'm going to say, but I'll do it anyways. So with regards to urology...
I very much doubt that, but yeah, I'll give it a go.
So with regards to urology, I think it's first key to say about what we mean when we say urology. So they have a whole host of different procedures. You can read it. So prostate, penis, testes, bladder, and ureters, and the kidney. And I'll go through each of those in turn just to give a little bit more background on each of them. Urology seems to have an inordinate number of abbreviations. So if you see any abbreviations that you're not sure of, just shout, and I'll endeavour to try and say all of the abbreviations as well. So the first one are all of the surgeries on the prostate. So the one that they most often do is the transurethral resection of the prostate, so the TURP. This is normally for benign prostatic hypertrophy or prostate cancer. So it's almost always old boys being operated on by old boy surgeons, and they're in the lithotomy position. So you can do them in general anaesthetic, and you can also do them under regional anaesthesia. If you're doing under regional anaesthesia, obviously figure out how quick your surgeons are and whether or not you need to do a spinal or whether you need to add in an epidural. One thing that I found interesting when I was looking this up is that they reckon that quite a common side effect, particularly if you're using regional anaesthesia with a TURP, is for the patient to get an erection, which prevents them from doing the surgery, which I can't say I've ever seen and didn't know about. But interestingly, they seem to suggest that giving people ketamine got rid of the erection and allowed it to go ahead. So that was something I learnt new, which I didn't know. If you ever get an erection, take some ketamine. So the main risks around that are sort of bleeding, TURP syndrome, and the anaesthetic risks with doing an elderly patient with comorbidities. There is a variant called the HOLEP procedure. If you see that, it's holmium laser enucleation of the prostate. But yeah, I don't think they do that at ESHT, so you won't see it here, but I seem to recall them doing up in Cambridge. The other surgeries that they do on the prostate are the prostatectomies. So these mainly fall into two categories. You've either got the open prostatectomy or you've got the robotic prostatectomy. The open prostatectomy is quick, nasty, bloody. The surgical time is in the region of sort of an hour and a half. But they will be expected to lose, I can't remember the exact amount, but probably up to about 1 litre of blood. And the reason behind that is because there's a whole bunch of blood vessels which feed into the prostate, which are behind the prostate. And they can't access that space. They can't get behind it to ligate the vessels before they take the prostate out. So they effectively have to go in, rip the prostates out, and then they have to fix the bleeding. Whereas that's where the idea behind the robotic-assisted prostatectomy comes in, because the robot, as you'll see later, has different angles of movement which allow it to try and get behind the prostate and ligate those vessels before they start bleeding. However, one of the things about it is that it's a long procedure when they do it with the robot. So you're talking sort of like most of the morning, if not the entire morning, depending on how quick the surgeons are. The theoretical benefit as well about the robotic-assisted prostatectomy is that it's slightly increased chance of being nerve-sparing, so you theoretically have better sexual function at the end of it. But Yeah. Penis. So realistically, there's sort of two main surgeries that they do on the penis. So it's sort of circumcision or cancers. Circumcisions are normally due to phimosis and they're elective in nature. And for us, from our anaesthetic perspective, it's quite a simple GA. I think you could probably theoretically do it under regional, but personally, if I was having my penis operated on, I'd probably rather be asleep. So bear that in mind. The surgeons will do, or they should do, a penile block to try and give good pain relief. So yeah, it's pretty simple from our side. The only times when that's an emergency is if they've got paraphimosis. So that's where foreskin is retracted, and it basically, because the blood flow through the penis is from the artery in the centre and then comes out through the veins on the outside, basically it gets venous congested and becomes swollen and having problems. Cool, someone's admitted Ahmed. Thank you. So paraphimosis can be a urological emergency if they can't retract the foreskin and return the foreskin to the original position. I think they normally, let the urologists guide you. In terms of the cancers, it's similar from our perspective. So it's the sort of semi-elective, similar circumcision. You can do it under a simple GA. The testes. So the main thing for the testes is, again, sort of scrotal expiation or cancer. So they like to do these in the middle of the night. They're almost always negative, but when they're not negative, it's drastic. And quite often they are this hydatid of Morgani, which is also known as the testicular appendage, which is actually the thing that's torted. And so the actual testicle's fine. There's always a lot of fun debate if you ever get a gynecologist and urologist in the same room, because the gynecologists don't get their query torted ovaries done in the middle of the night, but the urologists get their query torted testes in the middle of the night. So, again, GA is normally enough, like simple GA is normally enough. And the surgeons will do local anaesthetic to the scrotum, and normally that's enough. But you could do a sort of iliohypogastric nerve block to try and cover the scrotum instead, if you anticipate pain being a significant issue. Say they're a chronic pain patient or something like that. But normally just let the surgeon do their thing. With regards to the bladder / ureters, I've kind of put these two together. Because they often go in through the same place. So with the bladder, you've got the cystoscopy, and within the cystoscopy, you've got the investigations, the injections, and stuff they're doing with stones. So you can have the stones within the bladder itself. You can have the stones within the ureters. You can have the stones within the kidneys. In terms of the injections, the Botox is normally for irritable bladder. So it paralyzes the detrusor muscle to try and prevent people from having irritable bladder and Fowler syndrome and feeling like the need to go to the toilet the entire time. I think BCG, if memory serves, is used as a sort of local topical cancer therapy. I have no idea how they managed to figure out that BCG helps treat cancer in the bladder. I can only imagine there was some very rogue surgeon at some point who decided to inject BCG into the bladder, but who knows. With regards to stones in the ureters, so you also have this ESWL, which is extracorporeal shockwave lithotripsy. So for that, it's using ultrasound to basically shatter the stones and break them all up without having to pierce the skin. We don't often have to get very involved in those at all, really. With regards to the cancer surgeries, so you have two sides to this. You have the transurethral resection of the bladder tumour, so the TURBT. So this is similar to the transurethral resection of the prostate, where they go through the urethra into the bladder to try and resect. So it's normally if you've got sort of like a big bulky tumour inside the bladder, but where it's sort of locally invasive, but not through the muscular walls or anything like that, then they can resect it from the inside out, which is quite cool. And the other side of it are the radical cystectomies. So these are probably the biggest operations that we do in ESHT, and they, I believe, basically have an automatic HDU referral. So they will always go to HDU unless they're incredibly fit for a bed and breakfast. Now, if you're going to take out the bladder entirely, you have to figure out a way of where to put the urine afterwards. So the two options there are ileal conduits or neobladders. Ultimately, they're very similar in as much as they take a bit of the bowel and they connect the ureters to it. The ileal conduit is where they take a bit of bowel, bit of the ileum, and bring it out as a stoma, so that the patient can basically just has a stoma bag, but it fills with urine rather than feces. Neobladders are more complex, so they're a bigger surgery where they take the ileum and they sort of refashion it into a bladder, and then they can even connect that newly formed bladder that they've just made out of gut and connect it to the urethra, so the patient can pass urine through their urethra. I don't know how successful they are, but they like to do them, so I guess they must be quite good. These are, as I say, big surgeries. So the robotic ones, you would probably expect them to be done, like they would take pretty much the entire day. So one thing from an anaesthetic perspective that depends on the consultant that you're with, but some consultants will do the spinal at the end of the procedure rather than the beginning of the procedure, because if you do it at the beginning of the procedure, the chances are that the majority of the heavy lifting of the spinal and the local anaesthetic component of the spinal will have worn off by the time that you're trying to wake the patient up. So for analgesic purposes, they do it at the end instead. So with regards to the kidney, so they, again, can do stones. So you can, I can't remember what the name of it is that the urologists like to call it, but you can go percutaneously into the kidney to laser the stones to get them out. So if they've got, for example, a big staghorn calculus in their kidney or something similar, normally these patients would have sort of chronic pyelonephritis, recurrent pyelonephritis and renal colic. For the stones, they can also do stents, and when I say stents, I mean both stents to the ureter themselves, but they can also bring out a urostomy, whereby they're doing a percutaneous drain effectively into the kidney to divert the urine away. And those can either be sort of like intermediate procedures where they're planning on doing something down the line, say destroying the stone, or they can be sort of a palliative procedure as well if, say, the patient's got a big unresectable tumour and you just need to get the urine out. In terms of the nephrectomies, these are also big surgeries. So you can have them as partial nephrectomies where they obviously only taking part of the kidney, or radical where they're taking the whole thing. We most often do them here as robotic, which brings its own problems, that they're often in what's known as the jackknife position, where their sort of head is down and they're almost like at the top of a pyramid. They're that sort of triangular shape. And one of the issues with the nephrectomies is that the incision sites where they take the kidney out, because the kidneys are fairly large organs, they've got to do a relatively big incision just to even remove the kidney, aren't very well covered by either spinals or regional blocks. So, for example, the tap block is normally too low, rectus sheath is completely the wrong place, The spinal, again, is probably a little bit too low unless you get a really big dose of a spinal, and then you're running into other problems with regards to sort of your blood pressure and everything. So they can be really difficult to control post-operative from a pain perspective. One thing that we have in ESHT, which we don't have, which lots of trusts don't have, but is quite useful, is that the trust is happy for us to use sublingual ketamine. So I think it's actually an off-license prescription, an off-license indication for it. But you can give sublingual ketamine on the ward as a sort of adjuvant pain analgesic. What else to say about nephrectomies? I think the only other thing to mention about nephrectomies is remember that you're losing one of your kidneys. So even if it is a tumour-ridden, nasty kidney, it's still going to be producing urine. It's still going to be contributing to that creatinine clearance and the GFR. It's just remember that they are going to have a hit to their EGFR and sort of plan accordingly. Things like reducing dosages of drugs and potentially wanting them to be on HDU to kind of make sure that their kidney function hasn't gone off too far.